I was wondering why is it happening like this? Okay, you guys can see it.
Hmm.
Perfect, perfect. Good morning, Danny. Great to see you. I promise I'll refrain from profanity, and I'll be very, very.
No, we like it.
Of course you do, but no, it's hilarious. For the sake of the time and everything else, I was telling Michelle again. I cannot thank you guys enough for waking up that early. Leave on your mind to listen to this in the morning. That's not how you envision to start your day, but it's a packed day today. This is gonna be information heavy talk, lots of factual information. My suggestion is just follow. I'm gonna do the chat after the talk, and I do have a very juicy handout. It's about 7 pages worth of information, so you may take a note if you want to, but I promise you, I'm gonna send you slides and I'm gonna send you handouts, and you can just get yourself on a slightly slower pace to familiarize with everything we're gonna be talking about. I'm just gonna wait for the green light when Michelle tells me to go, and we'll get right into it.
I think people will be jumping on intermittently, probably, some maybe. And we can probably just go ahead. It's already recording.
Super cool. Okay. Good morning, guys. Again, thanks for joining me. So, I'm going to start with two cases, just to set the tone and understand why is it important. So, imagine you're working in pre-COVID era, because things were slightly different there, and you pick up a chart of, let's say, 76-year-old gentleman who fell at home. His daughter witnessed the fall. She was very concerned about it. After the fall, he couldn't get up, was complaining about pain to his left hip. He comes in. He's obviously in pain. His extremity appears somewhat shortened and somewhat externally rotated. You astutely obtain an x-ray, and sure enough, that juicy arrow points toward the fact that he may have some issue with his bones. He does have a hip fracture. He's in agony, he's in pain. Just so happened that ultrasound team was on the strike. They pissed that ultrasound machine was very dirty all the time, so they decided, screw it, we're not doing anything else. So they say, you know what, I need to control this patient's pain. And you go ahead and give him morphine. Sure, he seems to be doing just fine. Felt a little better, felt a little sleepy. Daughter was happy at the bedside, so dad is not moaning and complaining as much. You did your property workup. Let's say it was a beautiful day, that everything worked smoothly. Within, let's say, an hour or 2 hours, you managed to get him into a hospital bed. He's going to the trauma service. Let's say, for the sake of, he comes at 10, you're done around 1 o'clock and at 10 in the morning, and around 12:31 in the afternoon, you're done. He goes on the floor. And obviously not monitor bed, and around 7 o'clock in the morning, subsequently following day, you heard this horrific story what happened to him afterwards. So he gets to the floor, everything is fine. Around 7 o'clock in the morning, he hits his hospital bed, nice and beautiful. Around 6:45, right before the night shift come over, the gentleman was found unresponsive, and more towards, he was found in respiratory arrest. The code team, I'm sorry, the rapid response team was called. He was bagged, he was CPR'd, he was intubated and everything else. However, he remained persistent and systole, and just so happened that 45 minutes into resuscitation, he passed away. So 78-year-old comes in with a hip fracture, and 8 hours later, he's dead. Case number two, she's 36, essentially healthy. We expect she has a very bad case of hypertriglyceridemia, and because of it, occasionally she gets bouts of her pancreatitis. One of the days she comes in, prior to, for 3 days she couldn't tolerate any pure. She's been puking her guts out, and she's really, really in discomfort. She comes in, you examine her belly. It's tender, it's not rigid. She tells you classically, it's saying, my pancreas is acting up, please help me. Sure, I'll help you. And because it's been 3+ days, you've decided to get a CAT scan. Pancreas look like crap. She's in agony. You give her fluids. You're controlling her pain. And because she isn't so much pain, you decided to, I'm going to give her some hydromorphine. She gets, let's say, 1 milligram of hydromorphine times 2. Her triglycerides come back in thousands upon thousands, and she looks still unwell and bad enough. So she goes to an ICU bed. And 4 hours after she went to my ICU, all of a sudden the alarm bell goes off. Everybody ran into the room, and this woman was found to be seizing. So she got benzodiazepine, seizures stopped, and people were trying to figure out what the hell happened. So I have two cases. And the question is, there's some similarity to it. And as you know, the title of the talk is what happened. What happened is that physician who was taking care of these two patients. You want to take a guess who was the physician? Right here. My own cases. It just happened that physicians tend to neglect to look at the lab work, either before, during, or frankly after some of the pain medications were given. In the case of 76-year-old gentleman with a hip fracture, he did have a history of chronic renal insufficiency. And he hasn't been unwell for the past day or so, just flu-like symptoms. He wasn't, eating, drinking much and such. He had physician been astutely careful by the fact that he might have issue with his kidney. He would have noticed that his creatinine nearly doubled. In the case of acute and chronic pancreatitis, lovely lady, as I mentioned earlier, she's been vomiting for the past 3 days, and she started with prerenal acute renal insufficiency to the point that she managed to get some intrarenal component. Her creatinine shot up by 4 times. So in a setting of acute renal insufficiency, it just so happened that morphine and hydromorphine, unfortunately, did the first guy in entirely and contributed to this particular complication of near excitation known as a seizure in the patients who receive hydromorphine. Scary, really scary. And the thing is, you guys on the call right now, how often do we look at lab work before we give pain medication, specifically opioids or any pain medication to a patient? Very rarely, if ever, right? Or patient in agony has a kidney stone. I mean, listening, I want to just go back into the SEM, I was looking for the records and everything else. The point being, I may not necessarily, the bottom line of this talk is I might not need you necessarily to look at the prior visit, even though it's very prudent, but maybe at least just quickly ask the patient, do you have any problem with the kidneys or liver? And if they say yes, then you kind of need to then investigate a little more. Why? Because we're going to find out in 30 seconds. So we're going to talk about analgesic use in patients with renal and hepatic insufficiency. Topic is very dear to me because every single drug that we give to a patient either goes through the liver or eliminate through the kidney, and there's no way out, with a few exceptions, and we'll talk about this. So why is it important? And the problem is because as you might imagine, clearance and elimination of the drug is really, really altered in a setting of different degrees of hepatic or renal insufficiency. And we're talking about mild, moderate to severe. In the case of renal insufficiency, we even touch bases on end-stage renal disease, aka dialysis. In addition to impaired clearance and elimination, in intermediate metabolites, some of them can be more active than parental compound, can accumulate and can contribute to toxicities. And unfortunately, let's say in case of NSAIDs, as we all know, they do have tendency to exacerbate or aggravate pre-existing renal and hepatic disease. In addition to it, accumulation of the toxic metabolites lead to prolonged action, and I'll show you some numbers, and it's really, really concerning. There's some drug-drug interaction because of liver and kidney insufficiency, and obviously there's a safety concern and potential for dire adverse effect. And as you saw, a gentleman who unfortunately died because of opioid-induced respiratory depression in the first case. A few things to remember. I'm not asking you to memorize this, but just overall spiel. If a drug primarily metabolizes through liver, dialysis will have basically no help whatsoever. If a drug is a small molecule, it'll be more dialyzable. If it's more water soluble, it'll be more dialyzable. If it has a more protein binding, unfortunately, it will be less dialyzable. And if it's a larger volume distribution, less dialyzable. Do we need to know this? Not really. Should we know? Maybe, if you want to. These are the references. I put everything in a PubMed format in handouts and show notes, but these are the references I've used to put this talk together. First thing first, we start with acetaminophen. Despite the fact that we're on the time crunch, if you guys have any pressing question, please let me know. I'll shush and I'll be more happy to answer to your questions. So acetaminophen, dialyzable compound, has 5 inactive metabolites, considered to be one of the safest agents in renal insufficiency and renal failure. However, some of those metabolites, even though inactive, they have tendency to have a prolongation in the terminal half-life. And technically speaking, you should still be cognizant of the fact that if somebody has a moderate degree of renal insufficiency, you may want to extend the dose, and you may not want to go 1 gram every 4 to 6 hours. Maybe you can get a little dose into 650, even 5, and maybe you can go from 4 to 6 hours, maybe 6 to 8, and that's always recommended. Having said so, I need you to remind me one thing. When we get our VBG or ABG results, now we have GFR or we have a creatinine clearance. We have a reporting value. What is it? I'm sorry, I'm asking because I forgot. In addition to electrolytes and everything else, do you guys remember what our VBG printout has in it or reported? Is it creatinine clearance calculated for us already, or it's a GFR?
GFR.
Yeah.
You have to
GFR.
call pharmacy, they usually help you for like vanc levels and
Right. So
stuff.
we have GFR. GFR can be used as a surrogate. A person like creatine clearance. Obviously, formula is horrendous. Maybe we can figure out a way to do it relatively quickly. But just remember, anything with a normal renal function doesn't stays the same. Creatine about 30 to 49, which is a moderate degree of renal insufficiency. You probably can go to 325 to 650 at Q6. And creatine less than 30, be very cognizant of the fact that you need to properly lower the dose and extend the dosing intervals. Okay, despite the fact it's relatively safe. Now, when it comes to hepatic insufficiency, as we all know, too much acetaminophen have one of the toxic metabolite, right? NAPKI, I call this NAPKI, and blocks glutathione synthetase, and then will lead to all the insanity when it comes to acetaminophen overdose. So in the presence of liver cirrhosis, dosing should be significantly reduced. My suggestion, 50 to 75% down. But in the case of moderate to severe renal failure, pre-cirrhotic, you should not be using acetaminophen because the chance to have this toxic metabolite accumulates and having acute acetaminophen toxicity is very, very high. One more thing to remember, when you give pure acetaminophen to patient with moderate to severe degree of renal insufficiency, it's technically okay. The concern becomes when you utilize an acetaminophen as a part of a combination medication. Let's say Excedrin, right? We have acetaminophen, caffeine, and aspirin. Caffeine, aspirin, both exacerbate specific aspirin renal insufficiency. So then potential to accumulate toxic metabolite of acetaminophen will be higher. Similarly, Tylenol number 2, 3, and 4 with, let's say Tylenol number 3, with codeine can actually worsen renal insufficiency. We talk about this. So be cognizant of the fact that you prescribing combination analgesics that has acetaminophen to patient with renal or hepatic insufficiency. And that's it about acetaminophen. We're good? Perfect. NSAIDs, we all know, we've drilled this 10,000 times. NSAIDs do kill kidneys and gut and heart and everything else comes with it. Kidney seems to be the one that most commonly affected. They kill kidneys in dose-dependent fashion. It can be prerenal. They exacerbate vasoconstriction of the afferent vasovascular bed. And for that very reason, GFR goes down, creatine clearance goes up, goes down, and NSAIDs becomes really, really poisonous. Very simple. In case of renal insufficiency, renal failure, we probably should avoid oral and parenteral NSAIDs, aka systemic. And if you really press, you might consider using topical NSAIDs. Risk of systemic absorption are negligible. We talked about this, and you probably going to be able to get a better benefit for your buck by using topical NSAIDs if you need to, in the case of musculoskeletal injuries as well. When it comes to a liver insufficiency, there's some case reported up to 15% of patients that elevated LFTs have been reported. If you do have a patient with mild to moderate degree of renal insufficiency and you considering prescribing NSAIDs, you better make sure that they have some proper follow-up and they follow the LFTs. All right, they're not necessarily contraindicated, but the fact is they just need to be, patient needs to be clearly watched and several LFTs need to be done because if there's a rise in it, you should stop using NSAIDs. Ibuprofen, in theory, considered to be safer option in patients, but reality is there's no major difference when it comes to kidneys. Maybe ibuprofen is a little better than COX-2, maybe a little better than naproxen ketorolac, but once again, execute great deal of caution. And if you remember any of my studies we've ever done for pain when it comes to NSAIDs, patient with any degree of renal insufficiency were excluded because you really want to make things worse. Just some information, that bunch of active compounds, a couple of them are dialyzable, a couple of them are not. But once again, if you really, really press to utilize ibuprofen, make sure we stick to analgesic ceiling, and I would definitely suggest you to extend the dosing interval. I would do 400 Q10, Q12 maybe, but rather use topicals. And this is just information, normal creatinine, you're good to go. And if patient acutely oliguric, hold the dose or just don't give it at all. My suggestion, don't give it at all. Ketorolac is the poison. It's worse, probably the worst NSAIDs known to human when it comes to kidneys. It's contraindicated in patients with any degree of renal insufficiency. Renal patients have tendency to accumulate. Does not remove by dialysis. That's another problem with patients with renal problems. And in the case of renal cirrhosis or moderate liver insufficiency, you might consider significant dose reduction. And again, remember, once liver is out, technically, fully or partially, the platelets get somewhat jeopardized. And as we know, NSAIDs and platelets, they don't like each other much. So potential for increased bleeding is real when it comes to ketorolac dosing in a patient with moderate to severe degree of liver insufficiencies. As you can see, not recommended, contraindicated. So bottom line, any degree of renal insufficiency, avoid systemic NSAIDs, specifically ketorolac. Naproxen, despite the fact that it's easy to dose twice a day, it's actually worse for kidneys than even ibuprofen. And when it comes to renal insufficiency, renal failure, do not use it. Okay, not recommended, not recommended. And this is it about NSAIDs. Any questions? Okay, moving forward further to opioids. This is one of the most important slides, and as we all know, any degree of renal insufficiency and renal failure, please just risks versus benefit, right? We need to really elevate towards the fact that opioid-related adverse effect versus pain and see what's more beneficial. And if you believe patient needs something for pain, but stick to opioids that have least potential to aggravate and contribute to morbidity in the patient with renal insufficiency. Please consider utilizing lower dose, titration to the effect, make sure you extend those in intervals. Instead of every 15 to 20 minutes, maybe you can do an hour or two, depending how patients do. And most important part is on the bottom. Please, in patient with renal insufficiency or renal failure to that extent, frankly, even end-stage renal disease on dialysis, please avoid opioids with active metabolites. And here is why. When it comes to hepatic insufficiency, with the exception of two drugs, rest of the opioids are liver dependent when it comes to their biotransformation. In case of hepatic insufficiency or failure, lower initial dosing and titration needs to be very careful. And some certain opioids with active metabolites may not be even used. So be very cautious about this. And the question becomes, how do I know which one has active metabolites, which doesn't? Well, that's why we're having this conversation. The two drugs to remember, it's morphine and hydromorphine. Very commonly used, probably one of the most commonly used opioids by us. And these are opioids that have active metabolites that actually misbehaving in a setting of renal insufficiency. Why? Here's the why. Morphine has two active metabolites, morphine 6-glucuronide and morphine 3-glucuronide. Morphine 3-glucuronide is abundant. It's lesser degree of activity than morphine 6-glucuronide. Morphine 6-glucuronide has some analgesic properties, but the problem is it has tendency to really accumulate in the patients with renal insufficiency or renal failure. Its elimination as a metabolite, it's purely kidney dependent. If morphine 6-glucuronide accumulates, it leads to respiratory depression, arrest, and over-sedation. Morphine 3-glucuronide accumulation leads to seizures. If you guys remember what happened to gentleman with a hip fracture who received 5 or 6 milligrams of morphine by me, that's what happened. Because of his worsened renal insufficiency, morphine 6-glucuronide accumulated, and 8 hours into it, he managed patient to go into respiratory arrest. It is dialyzable, but in between the treatments, those glucuronide metabolites have tendency to accumulate, and they become poison to a person, and they have tendency to aggravate respiratory depression arrest and CNS depression arrest, and obviously seizures. So what do? Normal renal function, go ahead, do what you do, order morphine, titrate accordingly. Creatinine clearance about 49 to 30, 75% dose reduction. Personally, I would be very careful to the point I would not give it. Anything less than 30, avoid its use, okay? Including patients in hemodialysis. Please do not use morphine in patients with hemodialysis. They may do well with dialysis, they will have seizure or will stop breathing after treatment. When it comes to renal insufficiency, data is relatively limited when it comes to morphine. It does have tendency to precipitate hepatic encephalopathy. And the fact is because specifically related to oral preparation, the bioavailability becomes significantly higher due to a high rate of first pass metabolism. As you know, first pass metabolism drug needs to go to the liver, and only minimum amount of it gets extracted and goes into the bloodstream, while in a setting of liver insufficiency, significantly higher dose of morphine gets into the bloodstream, and then we're going to have very unhappy slew of adverse effect. In a setting of severe hepatic insufficiency and liver cirrhosis, I would strongly recommend avoiding its use. So bottom up, morphine is one of the worst opioids when it comes to patients with renal insufficiency and hepatic insufficiency to that extent, due to the fact it has two active metabolites that tend to make people dead or make people seize. So please, again, ask patient just plainly, do you have any problem with your kidneys in the past, or liver in the past? They may not know. Maybe single dose shouldn't be an issue, but subsequently to just try to pay attention to the creatinine, maybe GFR based on the gas, and maybe creatinine clearance. And based on it, make a solid decision. Should you continue the treatment or use something else? Hydromorphone, my nemesis, has one active metabolite, morphine, hydromorphone 3-glucuronide. It's not morphine, it's hydromorphone 3-glucuronide. I'll change it. The problem is this metabolite have tendency to accumulate in patients with renal insufficiencies. If a half-life of hydromorphone, its metabolite, in patient with normal renal function is about 4 hours, when it comes to patient with moderate to severe degree of renal insufficiency, that half-life goes up to 40 hours. 40 hours. So imagine patient gets admitted after hydromorphone have issue to it. The MIC is 10, 12, 24 hours after the initial dosing inside an agent. The people may not even know that it happened because of it, but it happens. It really did happen. It happened to me, and I believe it happened to a few other colleagues. Please consider lower dosing and definitely increasing dosing intervals. Good thing is dialyzable, bad thing is metabolite accumulates in between treatments, and people can have tendency to seize. However, if I were to compare hydromorphone and morphine, hydromorphone has a little luxury of being given a patient with mild degree to maybe moderate of renal insufficiency, because hydromorphone 3-glucuronide is still less toxic than morphine 6-glucuronide, okay? But again, be very, very cautious to do this. Normal creatinine, be my guest, lower creatinine, about 30 to 49, 50 to 75% dose reduction, creatinine clearance less than 30, even says it's 75% dose reduction, I personally would not use it. I would switch to something different. So you're telling me, so morphine's out, hydromorphone is probably out. So what's in? Well, my question when it comes to hepatic insufficiency, same thing. As morphine, avoiding hepatic insufficiency because biotransformation of hydromorphone is liver dependent. And should liver be not acting and not working well, the intermediate metabolite will accumulate and people might have some problem with respiratory depression and neuroexcitation as well. Well, this is the drug. Fentanyl doesn't have any active metabolite. And technically speaking, besides sufentanil and alfentanil, and the reason I'm not talking about this drug because we traditionally don't use them for pain medication. In the ED, fentanyl is one of the safest when it comes to renal insufficiency. Is it the safest? No. Yeah, some concern about giving fentanyl? Yes, they are. In patient who's beyond acutely uremic patients, a patient whose creatinine is less than 30, dose reduction still imperative concerns. And in mild to moderate renal insufficiency, you can use usual dosing, but just keep an eye on the patient. Problem is, it's not dialyzable. So if you give a dose, you just got to make sure that you're not going to exceed a dosing or administration intervals. It's very, very important to follow this. But again, fentanyl is much safer than hydromorphone and morphine. Normal creatinine clearance, you do your thing, 50 to 100 microgram IV. Creatinine clearance close to 30, I'd probably drop to 50%. In creatinine clearance less than 30, I would just use 75% dose reduction and definitely extended dosing interval. We are accustomed to titrate fentanyl with the frequencies of 10 to 15 minutes. Here, we should probably talk about hours, 1 hour, 2 hours in between. And obviously pay attention to patient clinical presentations. Questions about fentanyl? So morphine's out, hydromorphone is out. Fentanyl is your friend, and that's what I should have done to those patients. Once again, just make it simple. Any degree of renal insufficiency or hepatic misadventure when it comes to their function, consider fentanyl. But be cognizant of the fact, regardless of the fact it's safer, dosing reduction and interval extension still required. And in hepatic insufficiency, same thing, half or 1/3 of usual commencement doses need to be done, despite the fact there's no active metabolite, it still goes through the liver, and we need to reduce the dose. Codeine, monster, which should not be used at any point, but just to refresh your memory, one of several active metabolites, but the one that of concern is morphine. And as we just covered, morphine metabolized in morphine 6-glucuronide, and based on genetic predisposition, it can be ultra-rapid metabolizer, crap load of morphine, even so more of morphine 6-glucuronide. Bottom line, renal failure, renal insufficiency, say no to codeine. Say no to codeine. Dialysis, say no to codeine. Acetaminophen codeine, Even worse, it's a double hit. Say no to Tylenol number 3. In patient with renal insufficiency, same thing, because codeine is metabolized to active ingredients in the liver. Liver is partially or fully out. Say no to codeine. Oxycodone does have several active metabolites. One of them is oxymorphone, which tend to accumulate in patients with renal insufficiency. Half-life goes from 4 hours to 10, and therefore, in patients with moderate to severe degree of renal insufficiency, it may cause CNS toxicity, not seizure, rather than coma and oversedation, and unfortunately respiratory depression as well. Mild to moderate renal insufficiency, reduce the dose. Avoiding dialysis patient only because there's no data, really no good data, whether or not it's dialyzable or not. It's not dialyzable. Some of the metabolites may or may not. Bottom line, be very cautious when you consider utilizing oxycodone. All right, there's a different medication that may be slightly safer. If you press to use it, reduce the dose and increase the intervals. Creatinine is less than 30, which is a severe degree of renal insufficiency, no oxycodone. Creatinine between 50 to 30, 75% dose reduction, and extend intervals from Q6 to Q8 or Q12. So far, so good? Easy to follow, or I'm too fast? Okay, thumbs up, I love it. Thank you, Daniel.
Dr. Motov, there are
Yeah.
a few questions in the chat, just a couple. One of them is my question. In a patient with resolved AKI, meaning they had some AKI in the course of their either ED stay or up on the floors that now return to normal, would you still avoid like both morphine and NSAIDs or just kind of start low and then titrate up type of thing?
Beautiful question. I'll stick to the second part. No avoidance is necessary. If they recover completely, go for it. But you start the lowest effective dose for both medication and you titrate to the effect. It's hard to titrate NSAIDs, but the question is, if they recovered, they rebounded back to the baseline, have a normal creatinine and normal clearance, that age of 50 and above, you should go back to normal dosing regimen.
Okay. And would it make a difference if they had a bump in creatinine after having gotten NSAIDs in the first place?
Then you would not give them NSAIDs.
Okay. But would you say morphine is safe in that case?
Bump creatinine, again, creatinine as a number itself, people do pay attention to it. I would probably calculate creatinine clearance. Mm-hmm. And based on the number, even look at the GFR. I'm going to send you a different grid that look at GFR. And fact is that we have a GFR calculator for us, makes it much, much easier. NSAIDs sets everything for disaster. If you have a NSAIDs-induced renal insult, then subsequent administration of an opioids, with the exception of fentanyl, it will probably be very detrimental to patients' well-being. So I would probably wait till they fully resolve back to baseline, or I would use an opioid without active metabolites such as fentanyl or sofentanil.
Okay, cool. And then Adam's question was a good one. Does naloxone work on the metabolites of opioids?
Beautiful questions. Naloxone does work on metabolites of morphine and hydromorphone. Should you have patient with any degree of renal insufficiency, hepatic insufficiency, and they became bradypneic because they received opioids, you should be giving them naloxone.
And I guess there the concern would be, so is naloxone dialysable?
Naloxone, no, that's a good question. One of the article I came across to it, yes, but because it's such a short-lived drug, remember, it takes minuscule amount of naloxone, 0.04 mg, to reverse respiratory depression. And you just need to pace the patient afterwards. Most of the opioids, with exception of fentanyl, are dialysable, which means you give naloxone initially, then put them on dialysis, and you get a significant amount of it out. As long as you not continue dosing with opioids, you'll probably be okay.
So in the absence of dialysis, you would just need to watch someone very closely because naloxone might be temporary. And if the metabolites stay in the system, might have to keep giving naloxone.
Yeah, you're right. You put them on a drip.
Okay.
But avoid the drip, you just not give him opioids. Or you give him lowest effective dose, you start instead of 10, you give him 2 to 4, and maybe you titrate every 8 to 12 hours. But the fact that you're really paying attention to a patient. And when a patient gets admitted, you kind of need to convey this to medical team, which I didn't do, what I didn't know at that time, or any team, that they need to be wary of the fact the patient has renal issues and received an opioid in the ED.
Okay, thank you.
Great questions, guys. Hydrocodone, gets metabolized to hydromorphone. Again, hydromorphone, we just talked about this. Hydromorphone 3 glucuronide metabolite can precipitate, accumulates in renal insufficiencies and renal failure, causes seizure, dialyzable, but again, accumulates between treatments. So be very, very careful when you give hydrocodone. Again, suggestions, normal renal function, be my guest. Creatinine clearance 50 to 30, drop the dose almost 2/3. Anything lower than 30, do not give it because people's going to have issues with it. In a setting of hepatic insufficiency, same thing. Lower dosing, increased dosing intervals are must. Severe hepatic insufficiency to the point of liver cirrhosis, I would not consider using hydrocodone for the fact that hydromorphone is much more active and much more concerning when it comes to knocking off your kidneys and a liver fully. Methadone. We rarely, if ever, use methadone for pain, but again, we utilize a methadone for patients with opioid use disorder, and occasionally their comorbidities may predispose them to have underlying liver or kidney insufficiencies, and they're working as good. So good thing is that majority of metabolites, half of it goes out via urine and feces, and in patient with mild to moderate degree of renal insufficiency, methadone is essentially safe. Problem is its half-life in a normal people, it's about 96 hours. In the setting of significant renal failure, it goes up over 100 and easily, even if doubles. So that's why methadone may not be, it's a really, really good option for patients with moderate degree of severe degree of renal failure. And definitely I would not give methadone to patients on dialysis because it is not removed. In fact, as you can give methadone and 2 days later, patient have respiratory arrest and depression, and it's methadone related. So be very, very careful. Normal creatinine, same treatment, but once again, we don't use methadone for pain and it's less applicable to us, but just a common knowledge. In case of severe renal failure and dialysis patient, I would not consider using methadone. It's contraindicated in severe hepatic insufficiency, hepatic failure, liver cirrhosis only because of the accumulation and prolonged half-life, which may contribute to respiratory issues and CNS depression as well. Tramadol, I was like, tramadol has one active metabolite, which is much more concerning than parental compound. It does have tendency to accumulate in the setting of renal insufficiency and renal failure. Does, however, gets removed by hemodialysis, significantly to the point that you may give a tramadol to a patient, they feel better, they get on dialysis, and they just riding in pain because all the tramadol gets removed, including active metabolite, which means if patient to be continuing tramadol, which is a huge no-no for us ED guys, they may need to have a redosing while they're on dialysis right after because they just everything gets removed. But remember, tramadol should not be used in DD in any shape, form, and dose and such. Bad kidney function, we talk about the severe degree of renal failure. You can stick to 50 milligram dose, or probably do even 25. And as you say, dosing interval is Q12 instead of Q6. But my suggestion is avoiding normal people with normal renal function. Definitely don't give it to people with renal insufficiencies. When it comes to liver insufficiency, 50 milligram or less, dose interval should be extended to Q12. And if it's really, really bad real liver insufficiency to the point of need of liver transplant or patient liver cirrhotic, they should not be getting tramadol because active metabolites will accumulate and have some prolonged respiratory depressive effect. Buprenorphine, we used it on patients relatively more frequently now, just good to remember, is that buprenorphine does undergo liver metabolism and primarily comes out of via bile excretion. Metabolite levels are increased fourfold, however, in presence of renal failure. However, clinical implications of it really, really insignificant. And buprenorphine is probably one of the safest. In addition to fentanyl, it can be given to patients in standard dosing regimens for either opioid use disorder, or we can use buprenorphine to control pain in patients with renal insufficiency and renal failure. And when it comes to liver problem, there is not enough data to guide buprenorphine to it. My personal experience is bad liver, really bad liver, I'll be very cautious. I'll probably play with the dose a little bit, maybe dose in intervals. But data essentially doesn't point towards the fact that buprenorphine not as bad as morphine or hydromorphine. So let's sum this up. Opioid business. We got a few more things to go. And I got 5 minutes. In a setting of renal insufficiency, please avoid morphine. Please avoid codeine. Consider utilizing fentanyl. Obviously, fentanyl is there too, but we rarely use it. Oxycodone may be used with a great deal of caution, and extreme caution to the point of don't use hydromorphone, hydrocodone, tramadol. So I will be simplified this. Use fentanyl, cautiously oxycodone, everything else goes away. Is it simpler? Liver issues, I'm sorry, kidney issues, fentanyl is your friend, everything else goes away. From oral perspective, orally given opioids, oxycodone with significantly reduced dose interval and extended, significantly reduced dose and extended dose intervals is your friend. Everything else should not be given. If patient on dialysis, morphine goes away, codeine goes away, oxycodone goes away, and extreme caution again is methadone, tramadol, hydromorphone, fentanyl. I'd probably stick to fentanyl still, even though it's not dialyzable, but we can play with the dose and duration. Everything else needs to be really, really watched. And I would probably remove hydromorphone out of the equation as well, even though data believes that they could be safer. In a setting of hepatic insufficiency, say no to morphine, say no to hydromorphone, say no to codeine, tramadol, and methadone. What do we have left? Fentanyl and cautiously given oxycodone. Any questions about opioids thus far? So again, to make it very simple, guys, morphine is no longer your friend. Hydromorphone is no longer your friend. Stick to fentanyl if you can. And from orally prescribed opioids, you probably should be sticking to oxycodone. That breaks my heart to admit this, but it's safest. Although dosing might need to be reduced, we're going 2.5 mg instead of 5, definitely not 10. And once again, instead of Q6, consider Q8 or Q10. Few words on local anesthetics. All of them, amide or esters, will be affected by the hepatic failure. Clearance will be reduced and possibility of toxicity will be significantly higher. And same thing applies to renal insufficiency. So if you press to use them, consider utilizing lower dosing, drop them by 50%, but closely watch patients for cardiovascular collapse and seizure disorder when it comes to bupivacaine, specifically cardiovascular collapse and seizure disorder when it comes to lidocaine. Lidocaine patches, however, are much safer. Same as systemic NSAIDs. Say no to them and use topical, and I'd probably be very cautious with the local anesthetics. Unless you use an ultrasound guided nerve block, as long as you don't get into the vessel, you'll be fine. Intravenously giving local anesthetic in the patient with any degree of renal insufficiency, liver insufficiency should not be used. But lidocaine patches are your friends. Gabapentin tend to be safer, at least in theory. However, you need to drop the dose by 50% in patients in moderate to severe renal insufficiency. And frankly, people may have a relatively rather prominent CNS and even respiratory depression, especially when you combine gabapentin with opioids, which is unfortunately happens, not by us, but some other people. Good thing to know, it's dialyzable. These are the ranges when creatinine clearance is normal, creatinine clearance is reduced. The only thing is severely reduced creatinine clearance. Instead of doing 300 milligram TID, you're doing 300 milligram QD, but I would be very cautious to the point I might consider avoiding this medication in its entirety. When it comes to hepatic insufficiency, gabapentin is not associated with any misadventures, so you might consider utilizing gabapentin in setting of moderate to severe liver insufficiency or even liver cirrhosis, but kidneys not so much. TCAs, amitriptyline goes to nortriptyline, not removed by dialysis, and you just need to be cognizant of the fact that the patient needs to be watched for potential of developing, the anticholinergic syndrome and the cholinergic syndrome, whatever they do, anticholinergic syndrome, and dose needs to be reduced in renal insufficiency. Cases that TCAs are associated with the acute fulminant hepatic failure, and my suggestion, you either monitor, but the problem is we do monitor this patient, and that's the hardest part is. So if patient has a severe degree of renal insufficiency and to the point of liver failure, I would probably not consider utilizing TCA. I might stick to SSRI or something else if they're safe. And my body, I'm going to wrap it up with ketamine, undergoes extensive hepatic metabolism, has one active metabolite, but less active than parental compound. It's safe in patients with renal insufficiency and renal failure, and it's definitely safe in patients with hepatic insufficiency. So probably as non-opioid alternative, ketamine would be my drug of choice when it comes to pain management. So opioids, fentanyl, sufentanil, non-opioids, ketamine. Perfect. So let's sum this up. Safest, but remember, when you're taking safest, I want you to take it with a grain of salt. There isn't a safe drug when it comes to patient with renal or hepatic insufficiency. That's the most important thing. Safest, and based on what we've covered NSAIDs, acetaminophen, opioids, anticonvulsant, local anesthetics, ketamine, TCAs, bunch of drugs we've covered. But if we ought to choose just to make this sort of safer approach to it, alfentanil, buprenorphine, and fentanyl are our friends. In our D, we use fentanyl. Please consider utilizing it in patient with problem with the liver or kidneys. Buprenorphine, you may use it as well, as we talked about this. Ketamine, safe. Paracetamol, aka acetaminophen, safe. In a moderate degree or severe degree of insufficiency, reduce the dose a bit. And remember, be wary of combination drugs. Acetaminophen, aspirin, acetaminophen, codeine. These are no-no for patient with any degree of renal insufficiency. And why those are safe? Drugs without really good active metabolites and prolonged clearance are safer. That's why fentanyl, buprenorphine, and fentanyl comes into the place. Safer options in hepatic insufficiency, hepatic failure, fentanyl, hydrocodone, hydromorphone. You need to be very careful about the dose reduction, tramadol, lower doses, and ketamine. So I would stick to fentanyl. I would probably still consider a little bit of hydrocodone when it comes to hepatic insufficiency, low dose and extended intervals, and ketamine is our friend. Any questions? Anything in the chat that I need to answer right this very moment? So I'm going to wrap this up. Again, I'm not asking you to check creatinine, GFR, and clearance on every patient that you're about to give any analgesics. But when you do your H&P, like, remember, we're all guilty. Myself is guilty, and I showed you 2 cases that one patient ended up dying and one patient ended up having seizure because of sort of my clinical inadaptness to just at least look at the lab work afterwards. You know, initial single dose will not do harm. What happens is what happens next. And if you look at it and you realize, oh shit, they have a problem with the kidneys, their LFTs are up, or their creatinine is up, and GFR is significantly reduced to the point that creatinine clearance is less than 30, you just need to be cognizant of the fact that should you continue their analgesic regimen, just be careful. And that's it. If you have time, obviously, prior visits and comorbidities would be good. And of course, drug-drug interaction based on what the medication they're taking. All right? Any concerns, questions? It's not the most sexiest topic when it comes to pain, but it's very, very important, especially at Maimonides, because what's our average age? And if we add age to creatinine clearance, none of the patients will be given any analgesia, but that's not the case. So we'll be very good at geriatric emergency medicine, and this is just another layer of knowledge that tends to be too forgotten, but tends to be too detrimental to patients' well-being. So I'm harping on this long enough. Any questions, any last words, any concerns, any suggestions?
No, that was perfect. There are a couple of questions in the chat. We'll just leave it for you to answer over written answers because for the sake of time.
Sure. I am going to send this very presentation, and as I said, I have a very nice Word document, juicy notes, much more elaborative, and as a general knowledge, you guys, hopefully you like it. And as always, my email is open. Should you have any questions, anything, shoot me a message, talk to me, ask me questions. Don't be afraid, because I love questions. Michelle knows. And by now, you guys all know that I love questions. All right, my amazing friends, thank you for joining me. Sorry for not the sexiest topic, but we'll move on now. There are better topics coming up. But this is important. That's what kills patients. Everything else saves patients. All right, I'll see you in 5 minutes in a different venue. You guys fantastic. Thank you.
All right. Thank you very much.